It is recording and people are starting to funnel in. There we go. Go. All right, it's 5 o'clock. Let's get started. Hey, everybody. My name is Dwayne Ellis, and I'm a person in long-term recovery. And what that means to me is that it's been almost 6 years since I felt the need to use any mind-altering drugs to change the way I feel. And I speak out loud about my recovery because I was embarrassed. I was ashamed of what was going on with me for a long time. And a little bit in recovery too. I was just frightened, and I found a support network, and I felt lifted, and I feel powerful now. So I want other people to know that their voice is powerful. And that's why I speak out about my recovery. I'm also the workforce coordinator for the Georgia Council on Substance Abuse. And today's training will be the harm reduction basics. And our facilitator will be Riley Kirkpatrick. But before we get into that, I want to get into some housekeeping guidelines. Those who stay for the entirety of the training will get full credit for 1.5 CEUs. The CEU submission emails are being sent out by Larry towards the end of the year. Make sure you've been keeping up with your CEUs. An easy way to do that is just keeping track of the month, the topic, and the panelists. So for this one, it would be September. The topic is harm reduction basics, and the panelist is Riley Kirkpatrick. And in this case, no, I already went through that. You will not receive a certificate for the completion of this webinar, only a follow-up email from me thanking you for your participation, and also a copy of the PowerPoint presentation that Riley's about to give us. You will be muted throughout the webinar. Please raise your hand if you have a question, or submit your questions in the Q&A box at the bottom of the screen. And make sure that your real name is displayed so I can give credit to you. Make sure it doesn't say Samsung, blank, 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 or iPhone. Make sure it says your actual name. A little bit about Riley. Haven't known him long, but I saw him, and I saw him speak for the first time when I was in CARES 38. And I went into CARES 38 I wasn't as open-minded as when I left. And on the day that Riley came, he talked about a lot about Matt and Mar, and he made me eat my words. And that was the day where, I became open-minded to medicated assisted recovery, and that it is a pathway. So I appreciate Riley for that. He probably didn't know that, but it helped me out a lot. So without further ado, Riley, take it away.
All right, thank you, Dwayne. I didn't know that, but that's great to hear. I love it. So my name is Riley Kirkpatrick. I'm a person in long-term recovery. What that means to me is that I have a big, ginormous, beautiful life today that is free from the bondage of substances. And I'm about to say just a little more about who I am and what I do, but I'm so grateful not only to be here, but to be a CARES. And very much like Dwayne just said, CARES was a very large pivot of my own recovery. And this whole journey, these last so many years of what recovery has been and looked like, and how much it has changed and grown, I'm incredibly grateful for. And I love to be able to come back to the space that helped me grow and blossom so much. So I'm wicked grateful to be here. And with that, I'm going to say even a little more about myself. So again, Riley Kirkpatrick, I'm a CARES certified peer specialist, addictive diseases, and MATS, which is a medication assisted treatment specialist. That's through the state. My niche, or niche, if you will, has been medication assisted treatment, medication assisted recovery, medications for opioid use disorder. You could say use so much different language there, but that ultimately was the pathway that led me into long-term recovery. And I resisted it for many years as I did not believe that it was real or right or true. And lo and behold, knock on wood, it's years later, and here I am with a beautiful life. And I'm grateful I was able to open my mind there at some point. So what it is that I do now, and I've worn a lot of different hats as a CARES, but I'm incredibly excited that I am now the program director of Access Point of Georgia, Inc., which is a 501c3 nonprofit here in Athens, Georgia, that myself and two colleagues created from the ground up. We are essentially a harm reduction program, and we offer recovery resources. We offer a lot of different stuff. Essentially, we hold space. We hold a non-judgmental space for people who use drugs in our area. We offer everything from safe injection equipment to peer supports, education on various topics, advocacy, and recovery resources. And we collaborate with virtually every other program in the greater Athens, Clark County area. And we offer recovery supports in a lot of different forms. Everything from abstinence-based recovery, what you kind of consider traditional recovery, to medication-assisted recovery, to simply listening to someone who may be in active chaotic use, who's just struggling and needs someone to listen to them and to care about them. It's a very wide array of things that we do. And we are only the second program of its kind in the state. We've been working out of a parking lot, out of Divas Who Win Freedom Center parking lot for so long, and we have received grant funding, and we just signed a lease at a location, and we're waiting for the build out, and we are just absolutely ecstatic to be able to be building on this work that we're doing. And what this work is, we're about to learn about. We're not going to go super deep. This is kind of a like harm reduction 101, like we're just going to kind of cover the basics. But that's essentially what we're going to talk about. And with that said, we have a poll question right here, because I just want to get a little ideas to where y'all are at with harm reduction. What do you know about harm reduction? What's your relationship with it? So you want to pop that in there, Dwayne?
I already launched it. They're submitting. We got 41 people in here. 11 people did it. It's going. It's going.
Excellent.
Come on, y'all. Let's get to 100%. We're at 30. We need 11 more people to do it.
I'll spit these out too. What the question is how familiar, how comfortable are you with harm reduction? And just click on whichever statement best describes you, okay? I have no idea what it is. I have no idea what harm reduction is. The next one is, I understand the concept, but I don't know what it would look like in action. The next one is, I know what harm reduction is, but it seems edgy and controversial. And then the last is, I know what harm reduction is, and I'm a big fan. Just click whichever one of those best describes where you're at with your current understanding of harm reduction right now.
I think we maxed it out at 37. We got 97%, so that's good. Ended the poll. Results are being shared. You see it?
I do not.
Okay, so the results are, we got 59% that said, I know what harm reduction is and are a big fan. 22% say, I know what harm reduction is, but it seems edgy and I can't read the rest of the question, controversial. And then another 22% said, I understand the concept, but I don't know what it looks like in action.
Excellent. So the second and third one, those both were 22%?
Yeah, they were both 8 people for each of those, 22%.
Okay.
And then the last one, we had 22 people at 59%. Nobody chose the first one though.
Okay,
0%.
cool. That's cool. That's good to know. So everyone who jumped on kind of has a basic understanding as to what it is. Well, that's great. And I want to say too that I want this to be as tailored best to you all who are learning about this as we can, as I am able and capable of. So if you have a question as we go, either raise your hand or put it in the chat. Dwayne, what would you prefer there? Put it in the chat?
They can put it in the chat, yes.
Okay, go ahead and put it in the chat. If the questions get out of control, I might pause them and we'll go again. But I'll try to answer questions as we go. And I will have a spot at a certain point where we'll just have questions and answers. The first chunk of it though, we're just going to talk about kind of harm reduction conceptually, the concept of it, what it's about. And then at the end, we're going to talk about all kinds of specifics and what that looks like and how we can best support our peers through harm reduction lenses. Okay. Okay, so first off, we use affirming, respectful, and recovery-oriented language. And I say here in harm reduction, it's very important that we use person-first language. But as CARES, y'all know that we use person-first language also. And really, this is just like pushing a lot of the stuff that we learned in the CARES Academy even a little further. And I'll be the first to say, when I was in my CARES Academy, CARES 27, some of this stuff was edgy for me at the time. Absolutely. So we use language that is inclusive and accepting of diverse cultures, genders, perspectives, and experiences. Okay. So essentially, we will use language that where we can intentionally be inclusive to as many folks as possible. We use language that is strengths-based and hopeful. And what that means, like, if I was to summarize that, I would say language that is focused more on the positive than the negative. And a lot of harm reduction is about that. It's about focusing on what the person is willing to do, does want to do. We also do a lot of motivational interviewing, which I know those of us who went through the CARES Academy are hopefully at least somewhat familiar with motivational interviewing. But essentially that we focus on people's strengths rather than their weaknesses. If someone has a slip or a setback or is doing things that they wish they weren't doing, we won't focus on what they're doing wrong. We'll focus on their strengths. We use language that is non-judgmental and avoids assumptions. And I will tell you, this is a hard one. It is really easy to make assumptions about folks without even knowing that we're doing it. And again, that kind of comes back to what I just said in the beginning about trying to use language that is as broad and inclusive as possible. Also use language that is respectful, clear, and understandable. And I will say, like, I only have an 8th grade education. I got a GED, but I am not well schooled. I'm really not. But I was incarcerated for a long time. And when I was incarcerated, I read and read and read and read. And I don't think that I even realized how much my reading and sometimes writing like stretched my vocabulary. And sometimes I have to dumb down words. And I'm grateful kind of that, and other people had to say, like, what does that mean? Or, dumb it down. And it's not, I wouldn't say necessarily dumb it down, but like reeling in, just making things as simplistic and easy to understand as possible. Person first and free of labels. I feel like this one I could talk about forever. I just heard something there that was interesting. Anyway, person first and free of labels. So what that means, I feel like the bulk of you who went through the CARES Academy using person first language. It's where we identify the person as a person prior to the label. And what that means is that we don't use language like alcoholic and addict, which I know is like pretty radical for folks in recovery, because in 12-step culture, it's like that is a strong suit. We pride ourselves on that identification. If other folks want to identify themselves however they want to, that is absolutely 100% okay. But we will never call a participant a junkie or an addict or a tweaker or any of those kinds of language. I'd say the closest that we might do, like say we're talking to someone else in networking or doing a referral, we might say, you know, this person is struggling with stimulant use disorder, right? Or this person is struggling with opioid use disorder, rather than saying tweaker or junkie or, you know, is a really bad addict, those kinds of things. And I will say this one took me some time. It absolutely did. And it wasn't just about learning the words. It was about learning how to reframe into person first language. There are so many things that people are, there are so many things that I am, but I don't introduce myself. I mean, and I just think about it as cares. Like I introduce myself if I'm in a recovery space as a person in long-term recovery. And that's the same thing that I just said with like strengths-based and hopeful, like focusing on the person and the solution instead of the problem. I said I could talk about that one for a long time, and I really could. Okay, it's also inviting to individuals participating in their own journeys. And honestly, it can be difficult to even get someone to a point to where they want to participate in their own journey, okay? And I'm gonna be straight here, like a lot of the folks that we work with are in active chaotic drug use, okay? So like to even speak with them in a way to where they want to show up and participate in their own journey takes some work sometimes. I mean, we work with people on a wildly large scale. I'm going to switch the page. Do you have any questions so far, Dwight? Has anyone hit the chat?
Nope, you're good so far.
Excellent. Okay, history of harm reduction. This is kind of a fun one for me. Harm reduction is fairly new. It started with the HIV/AIDS epidemic, which, like, the HIV/AIDS epidemic really was kind of at different places in different years, but it all has been really pretty remarkably fast. So the term harm reduction was coined during the height of the HIV pandemic, rooted in the radical belief that we take care of each other because no one else would. And that's how harm reduction started. It was a bunch of boots on the ground, people on the street helping each other. It was people that were horrified because they were burying their friends in such high numbers and at such an insanely high, fast rate that they couldn't keep up with it. And honestly, like, I think about it and compare it sometimes to like where we're at with the overdose crisis right now. And we'll talk about that in a little bit. But that same like feeling of powerlessness, and absolutely, I'm not going to compare this part, but the stigma was absolutely insane. Absolutely insane. People would come up positive, you know, and there wasn't even a word for it, like human immunodeficiency virus. Prior to that, they called it gay cancer. All that they knew was like gay men and junkies, like IV drug addicts. That's all it was. And the stigma was so absolutely insane. And people would be dead within 6 months to 2 years, just incredibly fast. There was absolutely no money put into research. It was years before Ronald Reagan even spoke a word of it. They finally learned that it was in semen and in blood, which is where it was spreading so quickly in the gay male population and in the IV drug use population. But even after that, it was still years and years and years of stigma surrounding gay men and IV drug users. And it was a radical approach for folks to help each other. People started popping up with what they call drug user unions. And what it was folks who were using drugs who were like have this attitude kind of that like, my drug use doesn't deserve me to die. Like, I am still worthy of medical care. I am still worthy of treatment. I am still human. And I mean, it feels sad to have to say that, or that people had to like politicize their lives, but they did. The very first union was in Liverpool it was like 80, 81, and hepatitis C, run rampant. The generation before me, massive amounts of hepatitis C. They were the first to have a needle exchange, and that was in Rotterdam. The second was in London. And then the first one here in America was in New York City. And then the second was in Tacoma, Washington. And I'm from Olympia, Washington. And I used to use that exchange in the early 90s. I had no idea like where we were at in the history of stuff, but still it made it accessible. It made clean syringes accessible for me. To the political context, harm reduction was a response to the war on drugs that was disproportionately affecting people of color and poor people. And I will say here, like, harm reduction isn't just about the harm that is created from one person. It is also the harm that's created in a community and the harm that is created with society at large. Some of that's based on stigma. Some of it's based on policy, on the criminalizing of, what we call a disease, of a public health issue. We'll talk more about that in a bit. But that's the history in a nutshell. If anyone is even remotely interested in this, there is a book called Undoing Drugs by Maya Solovitz. This just came out like a month or two ago. Beautiful piece of work of collected stuff. You can bounce around in chapters too, but really walks you through the history that got us from where and why and how, and some of it's heartbreaking, to get us to where we're at now. I can remind y'all about that at the end too. Oh, and I forgot to say at the beginning, but if any of y'all want these slides, I can email you, either Dwayne or myself can email the slides if you're interested in having the information. I meant to say that at the beginning. Okay, how are we? Do we have any questions yet?
Nope, we're doing good so far.
Excellent. Okay, so what is harm reduction? It's a set of practices and principles surrounding drug use and often sex work. Harm reduction is the way in which the foundational approaches of harm reduction, it also works very well in the sex work industry or field. I'll put it that way. Okay, so it's a set of practices and principles, and we will go through those principles in a bit here, surrounding drug use and often sex work, put in place in order to reduce the amount of harm done to people and their surrounding communities. Harm reduction is also a movement for social justice built on a belief in and respect for the rights and dignity of people who use drugs. Just that, like, I feel a little bit of shame in saying this, but my first few years of recovery, I got really self-righteous, which I feel some shame in saying now, but I did this thing where I looked down on active users, which was kind of crazy because I myself felt so incredibly stuck there for so long. And just the concept, I mean, I had sponsees that I worked with. There were people when people would struggle, when people would relapse. I had this really, I mean, I don't know what to call it, except just that, like, I didn't have respect for people that were struggling with getting it. And when I say it, I mean 100% abstinence all at once overnight. Like that narrative of hitting a bottom, stopping all at once, and never using again. And if that wasn't their process, I wasn't the kindest. And I feel a little shame in saying that, in that, like, I'm so wildly different now, but it can be an easy attitude to have. So harm reduction, again, it's a person first approach, and it often looks like radical acceptance, compassion, love, and support, no matter what. I feel like I've talked about that in a few different ways, and I will continue to do so, even in talking about the history and the unions and people advocating to just be seen and treated with dignity and respect, and to have their humanity intact while they're still struggling with substance use. I feel like I see a lot of it a lot more clearly now, in how culturally we are so unkind to people who use drugs and to people who struggle in the getting it. I'll put it that way. Harm reduction incorporates a spectrum of strategies, from safer use to managed use to abstinence, to meet drug users where they're at, and address conditions of use along with the use itself. And this was something that was kind of radical and edgy for me in the beginning, because I had been told the narrative so much that, essentially either you're clean or you're not. And like, this kind of language I don't use anymore at all, but I did not in any way understand that there was any kind of spectrum, and like spectrum of use. And that looks like everything from like chronic, daily, chaotic drug use, all the way to total and complete abstinence. But it was like there was either one or the other. There was no spectrum. And I literally felt like I was not allowed to support people in places of that spectrum. And in so many ways, that is what harm reduction does, is that we support people in reducing the amount of harm. And these are some specifics that I wasn't going to get into till later, but like, if that looks like going from, IV drug use 7 times a day to 3 times a week to once a week to, maybe they're getting really bad abscesses, and then the next best thing is to find a different route of administration, right? There are so many people who learn to care about themselves as a process, and those people absolutely deserve to be supported. To whereas I did not have the frame of reference as far as that process thing. And I really thought it was this black or white thing, and would do things and say things like, oh, you know, come back when you're ready, or, you know, you got to hit your bottom. Once you've hit your bottom, then you'll be willing to do whatever it takes. And refuse to support people in that space. And I remember being wildly confused. Like I went to inpatient treatment 14 times. And I was kicked out of a lot of those places, or they would tell me, like essentially I would go to a place for being sick, but would be like too sick to be there and would be discharged. And in harm reduction, we do everything we can to not discharge. We will show up and be present with someone and support them and love on them no matter what. That support is not contingent upon their ability to stop using substances. We will continue to support them.
I got a question now, Riley.
Question?
David Whiter says, so does this last slide suggest or imply that the goal of harm reduction related to substance use is abstinence for the service recipient?
The goal of harm reduction is to reduce the amount of harm. And for some people, that absolutely will be abstinence. And for some people, like, and I don't mean to be really dramatic, but I mean this, like for some people, it looks like them not dying. Like that's it. Like there are folks we give clean syringes to, we give Narcan to, naloxone, we give them fentanyl test strips. We are in such a crisis of overdose right now. And I just had these stickers made that said, people can't recover when they're 6 feet under. Narcan saves lives. And like, there are elements of harm reduction that's it. There are people that I work with where the only thing that I hope is that I see them again next week and that they are alive. And at the rate that bodies are dropping, I personally am okay with that being enough. You know, like I believe that it can get easy to almost have this element of self-righteousness in recovery sometimes, where we expect our bar to be someone else's, and that just is not always the case. And I want to be clear too, that like, I am completely aware that I am doing this webinar to other cares who have already, and then some other folks too, but intentionally for other cares who have found their own personal pathway to recovery. Like my intention here isn't to, you know, get anyone else who is already comfortable and confident in their own pathway to recovery to switch over to harm reduction for their own process. Like that's not the intention. The intention is to educate ourselves enough and to be able to open our minds so that this work that we're doing, we can actually do it in a way that can include the folks that are actually dying and that are spreading disease and that have to live with HIV and Hep C and all of these things. And statistically, like we know that harm reduction works. We know that harm reduction keeps people alive and reduces the amount of harm. You feel me? So that was a whole lot in there to say, but abstinence might be the end goal. It absolutely might be. And it might not be. It's up to the person. But ultimately, the The important part is that I will support the person when they say what it is that they want, rather than me speaking over them and saying, no, 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 no. I'm going to pour you into the mold of recovery that worked for me. And I'm not going to support you unless you do it this way. And then people fall to the wayside. They feel a whole bunch of shame. They go use in the dark, in the corners alone. They overdose. They like all of these things. And that's what harm reduction is saying, come here, like, I love you. I support you. What do you want? And I'm going to support you every step of the way until you get there, wherever that there is. And whether it's abstinence or not depends on them. But one thing I will say, like specifically with syringe service programs, people who use syringe service programs, needle exchanges, are 5 times more likely to go to treatment. 5 times. That's huge. That is a huge number. There are so many people in active chaotic drug use that don't, like, we are their only visual and face of recovery. And if they feel safe with us and comfortable with us, they trust us, and then they start talking to us, and this whole thing snowballs. I'll stop there. Did that either help answer the question, or are there other questions?
Prevent suicide.
Nope.
Well, as a PA, we still need to
Okay, I think that was a mistake. Okay, one more slide on harm reduction. It is not the opposite of recovery. It is one pathway of many that is often a more patient and sustainable route for many. And again, I want to be really clear that this isn't about like one person, one kind of person. This is the one and the only way. It's not like that. Like, some people get it slow and steady. Some people get it overnight. Some people never get it. Doesn't really matter though. It's not for us to say where they are at, if they're worthy of support. They are worthy of support. Harm reduction, it is an approach to treating those with substance use disorders that does not require patients or peers to commit to complete abstinence before treatment begins. Instead, an array of practical strategies are deployed to reduce the negative health and social consequences of substance use. You feel me there? Like, we never put conditions. I mean, if somebody's violent and abusive, like, that's one thing, but like, we will never turn someone away because they're using and they're not supposed to. We will encourage them and support them however long it takes. And that could look like all different things.
Hey, Riley.
Yeah.
Marissa asks, how many needle exchanges are there in Georgia?
Above the table, 2, and we are number 2. It's bad. It is really bad. We've had people come to us all the way from other side of Warner Robins. And like, you know where we're at on the map and where Warner Robins is, it's real bad. We are a needs-based, meaning we can talk to people and kind of give them what they need. The one in Atlanta is what's called 1-for-1. So they can bring in 1 syringe and they only get 1. They don't have very much money though. Like, sometimes people will bring in 40, and if they don't have enough, they'll only give them 10. We're not like that. We will give people truly what they need. And we give them sharps containers to bring their dirties back. I'm about to get into a lot of the specifics with the SSPs. So I'll answer all of that stuff. I just have, like, I think maybe 1 or 2 more slides that's kind of conceptual about harm reduction, and then we'll get into those specifics. Cool.
Yep, she said, yeah, I searched online and only 2 existed. We're in Macon and there's nothing here.
Yeah.
And Jamie Toludo asks, what is SSPS?
Jamie. So SSP or SSPs, it's an acronym for Syringe Service Program, which is just new modern language for needle exchange. So an SSP essentially is a needle exchange. We do so much more services than just needle exchange, and needle exchange is kind of one of those things where it's still stigmatized, or it's like calling an opioid treatment program a methadone clinic. You know what I mean? Like you say methadone clinic and boom, people get this automatic visual, but like really it is an opioid treatment program. It's that exact same kind of thing. I'm just about to get into all that. I will tear through these so that we can talk about that kind of stuff. Okay, so also it aims to change behavior according to the goals of each patient, or we'll say here each peer, whether that means moderation of use or complete abstinence, anywhere in that spectrum. In harm reduction, complete abstinence is a choice to be made by the person, not a condition imposed by a treatment program. That's a good way to summarize what I was just saying. A basic tenet of harm reduction is respect for patients and their capacity to change. Okay, this is my last slide about this stuff. And this is a big slide. There's a lot on there. And this was pulled straight from the Harm Reduction Coalition out of New York City. They are an amazing, amazing program. I almost went and worked for them because I'm so in love with harm reduction, but then was like, what am I doing? I don't actually want to live in New York City. Anyway, this is from that. So number one, accepts for better or worse that illicit drug use is part of our world and chooses to work to minimize its harmful effects rather than simply ignore or condemn them. And y'all, that is a huge thing that our society does. We have this like just say no thing and just like, you know, be smart, make good choices, say no to drugs. And like it's just not how it is. And there is a supply and demand, and that's just what it is, no matter how much we feel about it. So number two, it understands drug use as a complex, multifaceted phenomenon that encompasses a continuum of behaviors from severe use to total abstinence. And that's that spectrum that I was talking about. And acknowledges that some ways of using drugs are clearly safer than others. And I don't know if you noticed this, but there's always the word safer. We talk about safer injection. We never actually use the word safe. Okay. And I just want to like point that out because we can try to reduce the amount of harms, but there are still harms. It's just how it is. It's part of that acceptance. Number three, it establishes quality of individual and community life and well-being, not necessarily cessation of all drug use. Cessation means stopping. Okay, so it doesn't necessarily mean stopping all of drug use as the criteria for successful interventions and policies. And essentially what that means is that if somebody went from shooting heroin and fentanyl 8 times a day to only smoking pot, like we are going to support them 100% and not be mean to them and not tell them they're not doing it right. In a nutshell. Number 4, it calls for the non-judgmental, non-coercive provision of services and resources to help people who use drugs and the communities in which they live in order to assist them in reducing attendant harm. Number 5, ensures that people who use drugs and those with a history of drug use. Do you guys notice this keeps saying people who use drugs? Or they'll say people who inject drugs, and that is person first language over and over. Okay, it ensures that people who use drugs and those with a history of drug use routinely have a real voice in the creation of programs and policies designed to serve them. And we do that. We often talk to active users about what it is that they need rather than us telling them what they need, because they're the ones being served. 6, it affirms people who use drugs, and that's an acronym for PWUD, people who use drugs themselves as the primary agents of reducing the harms of their drug use and seeks to empower people who use drugs to share information and support each other in strategies which meet their actual conditions of use. Number 7, recognizes that the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination and violence, I'm fitting that in there, and other social inequities affect both people's vulnerability to and capacity for effectively dealing with drug-related harm. That is a huge one. I could speak on that for an hour. In 8, it does not attempt to minimize or ignore the real and tragic harm and danger that can be associated with illicit drug use. So I guess that's the last one. How can it help? Harm reduction, it gives people more options, all right? They can want to be present with us if they know that we'll support them if they're still using. They don't just close up shop and never come back. There's often less resistance to change. It gives those in need a voice. There is less judgment with harm reduction. Safe consumption and needle exchange programs dramatically reduce infectious disease, overdose rates, and helps those who wish into a recovery pathway. And that's what I was saying earlier about 5 times more likely to go to treatment. Harm reduction dramatically lowers the financial cost to communities. Holy cow. You know, I'm just going to say this. It costs approximately $400,000 to treat someone with HIV over a lifetime of medication and medical expenses. $400,000. Y'all, it's anywhere from like 16 to 30 cents for a new syringe. Right? Like, that's kind of a no-brainer to me. And that's what we do. We go straight to the point of the problem, which is the transmission, which is the syringe. But in so many communities, when they learn that, when they understand that, like how much harm reduction actually truly reduces harm and financial harm of entire communities, it's huge. Harm reduction meets people where they are, but does not leave them there. And I love that. I love that saying, we meet them where they're at. We don't force them to be anywhere different, but we are constantly present with them and offering them options. And it's very kind. We don't force anything. And again, it's never coercive. There's never ultimatums or anything like that. So this was a space for Q&A stuff. And here I say, after this Q&A, we will get into some specifics of what harm reduction work looks like and how we can best support our peers. Do y'all have any questions about the harm reduction kind of as a concept, like conceptually, or do you just want to get straight into what it looks like talking about syringe service programs, medication-assisted treatment, naltrexone, naloxone, Narcan, that kind of stuff?
So Marissa asked earlier, I forgot to get to her question, the average cost of a needle exchange.
Oof, okay. What do you mean there? Like, you mean for
the program itself?
What does the program itself cost? That's a big question. We started slinging syringes out of the back of my car in the parking lot at Divas, right? And every single dime that we made went to supplies. And then any work that was done is donated. And I cannot tell you how many thousands of hours that have been donated. That's just so hard to say because it depends on so many things. I will say though, one thing that, man, I just cleaned my desk, but on last Wednesday, in a 2-hour period, we had 58 people come to us for syringes. And we exchanged, I want to say like 2,100 and something, like over 2,100 syringes, and had 58 people in front of us in a 2-hour period. And we haven't even been open a year. And we knew the need here was great, but it has blown my mind how great the need really is. So it just kind of depends. I am literally employee number 1. And because we got this grant, I'll be able to pull a salary and we're able to be in a location. But it just wildly I can't answer that in a numbers kind of way because it massively depends on what you're doing and how you're doing it. If you're passionate about it though, we have been able to do an incredible amount of work and affect an incredible amount of change and touch in a lot of people's lives without, I wouldn't say that much money spent. I mean, I can look at what we spent in the last year if you're interested, and we can talk later.
And then
yeah.
Ty says, I'm sorry to interrupt. Were you still talking?
You're good. You're good.
Ty says, is CBD, it's 0.3% or less THC, is it considered part of harm reduction? If relevant, could you speak a little to the role CBD is playing in Georgia recovery world? Thanks.
Anything that is less harmful than the other thing is a reduction of harm. And we use language like a hierarchy of harm. And just what that means is that there's the super harmful things and then the things that are less harmful. And that's what can be really difficult is that, some people may be, and I'm just going to use some examples and I want to be clear that they're examples. Some people may be in abstinence-based recovery. Abstinence-based recovery is where they want to be. And, using some form of substance for some reason, that may be a bit of a going backwards kind of thing. But when somebody's, shooting fentanyl 8 times a day, and then you talk about CBD, oh my goodness, if they were using some kind of CBD oil, regardless of the percentage and not the fentanyl, that is huge. And that's one reason they're trying to decriminalize marijuana in so many places, because there were so many people addicted to opioids that if they have access to a safe supply of marijuana, the amount of harm is massively reduced, massively. So I can't answer that in my judgment. I can just say it depends on what you're coming from. But I mean, it's in the title, harm reduction, where is the reducing the amount of harm? Or there's people that CBD is an amazing alternative to benzodiazepines. I mean, who wants to be strung out on Xanax when CBD oil is could be amazing for somebody that's the alternative, So I hope that answers your question. I know it's not too specific about CBD oil itself, but it's the, what's the lesser of the harms?
Yeah. And David Whiters just wanted to share an example. He was an example might be teaching PWID how to smoke heroin as a strategy for reducing their risk for overdosing. I can't pronounce that word, endocarditis, HIV, and HCV.
So essentially what he's saying is that people who inject drugs, and that's PWID. So people who inject drugs who are using their substances by smoking them rather than injecting have already decreased their likelihood of death. Okay, which is a good thing. And he's using that as an example. Endocarditis is a bacterial infection that happens around the heart. That is one example of many of, like, it's a very harmful thing. People die from it, from injection drug use. But if they're smoking, they're not doing that. There was the People's Harm Reduction Coalition in Seattle literally created, they called it the hammer. Like, they created a pipe in which people could smoke tar heroin as a, like, because so many people were getting endocarditis and so many people were overdosing from doing the same size hit that they did the day before. Like, anything that can reduce the amount of harm is worth it. And I just, like, we haven't even gotten to it yet, but, like, y'all, we had over 93,000 people die last year from overdose. It was up almost 30%. It was like 29 point something percent increase in only 1 year. Like, the overdose crisis is off the hook. It is crazy. And, like, yes, I would love to, like, you know, I don't know, be running through, like, here's recovery and recovery is so great and this is abstinence and blah, 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 blah. And it's not freaking realistic for a lot of people. It's just not. And the people it's not realistic for, I still don't want to see die. I don't at all. And the, like, that's just that concept and that conversation of encouraging people to reduce harm. And I've done this work long enough to know that when people feel safe with you and they trust you and you don't judge them, something magical happens. I mean, the same magical thing happens when we connect with each other, when we connect with other abstinence-based folks. Like, wherever they're at in their substance use, it doesn't negate the fact that they are a human that desperately needs connection. You know, and we learned that in the CARES Academy, that the opposite of addiction is not sobriety. The opposite of addiction is connection. That's what a lot of this is about.
Incursion was, she was saying, or another example that doesn't include changing method is using a clean syringe every time, never using alone, and having Narcan reduces disease, reduces overdose, and that PWID is able to live another day.
Is that Kirsten Lester?
Yeah, that's Kirsten Lester.
She volunteers with us at Access Point, and is another CARES on the front line of harm reduction, which is awesome. Absolutely awesome. Okay, I'm looking at the clock here and I want to tear through some of this. I'm going to tear through some of these next few slides, just talking about some of these specifics. All right. So naloxone, Narcan, if you went through the CARES Academy, remember when Lori and Robin came and probably gave you a box that looked something like this, right? Or maybe something like this. These here, this literally saves people's lives. Like, saves people's lives in the most intense, extreme way. And it is, I'll just read this here. It is an antidote for opioid overdose. It's an opioid agonist, meaning that when given in a timely manner after opioid use, it can reverse the effects of an opioid overdose. I will say though, and I didn't understand this until we started doing this harm reduction, the closer that you get these into the hands of people that are actually using, the more often and more likely it's used, right? Like, people can carry these in their cars and like hope or think you might bump into someone randomly. But when people who use drugs have these and they hang out with other people who use drugs, and it is right there, It's mind blowing. We had one of our first months that we had, and I've given a lot of this out in different settings, but I think we'd given out maybe like 47 or 49 kits, but we had like 11 or 12 reversals, like people who actually used them during an overdose and literally like saved the person's life. And I was like, holy cow, like getting these into actual users' hands is wildly important. It really is. Medications for opioid use disorder, also known as MAT, medication assisted treatment, medication assisted recovery. There's a lot of different language for that right now. Things like Suboxone, methadone, naltrexone, Vivitrol to assist in the treatment. And again, SSPs, syringe service programs, formerly known as needle exchanges, help reduce risk, and people who inject drugs have access to safer injection supplies and practices, and can receive resources for treatment if they so choose. I just talked about a bunch of that. I won't go too far into it. Around here, these are the two popular ones. This one here, the box, the 4 milligram Narcan nasal spray, that's a nose spray. And Narcan, so this can get kind of confusing, but it's not that hard. Like naloxone is the name of the medication and Narcan is the brand, if that makes sense. So like this kind here, it's intramuscular. So like where there's the IM syringe and the little vials, that's naloxone. That's the name of the medication. Narcan, and then it says naloxone right by it. It's kind of like how Tampax is a brand name for tampons, right? Like what they are is tampons, but Tampax is the brand. It's kind of like that. Or like Kleenex. Cute, yes. Absolutely. Another example, yes. Or like how Kleenex is a brand name, but it's tissue paper. Yeah, it's like that because it can be confusing. Like Narcan, naloxone, what's what? It's just one of those like pharmaceutical company things. So medications for opioid use disorder. And I do, if you've been through the CARES Academy in the last so long, you might have heard my very long thing around medications for opioid use disorder. And I'm saying medications for opioid use disorder because this is the last probably couple years that SAMHSA has suggested this language because we were going back and forth from that. People were arguing of like medication assisted treatment, medication assisted recovery, whatever. And I won't even get into all that. But you possibly like heard all my stuff around that. I'm not going to get into all that stuff. I will say that, you know, I'll read this. Medications for opioid use disorder is considered the gold standard, not just medications, like specifically methadone. Actually, methadone has the highest success rates of any other form of treatment for chronic long-term opioid use disorder. I just said that. Okay, now, even if someone begins taking medications for opioid use disorder, and they do not engage in any other form of therapy, they still automatically are 50% less likely to overdose simply by taking the medications. That is a form of harm reduction, okay? So when I do that big, long training around MAT or MAR, and we talk about this and that, and we talk about it as a valid pathway to long-term recovery, and we talk about it as a pathway to abstinence. And, you know, what is abstinence, and is it, you know, all of that. Even if all of those things, when we judge people about not doing it right, even if somebody begins taking Suboxone or methadone, and even if they are not doing it in the ways that we deem are right, they are still 50% less likely to overdose. Okay. So again, if we're coming back to the like looking through the lenses of just trying to reduce harm or just trying to keep people alive, it is still harm reduction, even if it's not like meeting the bar, like the abstinence-based bar. Okay. Jamie was asking about this earlier. What are syringe service programs, also known as SSPs? Some people will say SEPs, syringe exchange programs, syringe service programs. Syringe services are programs that allow injection drug users to trade in their dirty, already used syringes for brand new clean syringes. This massively decreases infection rates of HIV, hepatitis C, endocarditis, which Dude was talking about earlier, and abscesses, to name just a few. It also helps keep dirty syringes off the streets and sidewalks and prevents needle sticks to police and healthcare workers. People who use drugs can also learn about many other services at the same time. And they do. The longer they come, the more they start asking questions. And again, I said this earlier, this statistic is just huge. Like, it is absolutely huge. Drug users who access syringe service programs are 5 times more likely to receive treatment than those who don't. That is mind-blowing. And I just see it as like people who inject drugs, especially in rural counties, like out in the middle of nowhere. They have no friends in recovery. They don't know anyone in recovery. They don't anything. Like they would never, there's no places like ours for them to show up. That's like not even a thing. And we have people come to us and they're like, you do what now? Huh? Like, it kind of blows their mind that we're just there to help them stay alive. And at first they'll be like looking around like, you sure this place isn't under surveillance? Like, it takes them a minute to understand that like we really are there for them. Like, there's no catch. There's not a catch. We want them to stay alive. And I've really grown to just like, of course I love people in recovery, but like, I love drug users too. I do. I was one for a really freaking long time. I was. Okay, a little more about SSPs. They are associated with an estimated 50% reduction in HIV and hepatitis incidence. When combined with medications that treat opioid dependence, also known as medication-assisted treatment, which I was just talking about, hepatitis C and HIV transmission is reduced by over 2/3, okay? So that essentially means if somebody who's actively out there in the world using and is just flat out using and is injecting drugs, if they are receiving services from an SSP, and if they engage with some form of MAT, like some kind of opioid treatment provider, they're automatically 50% less likely to get HIV or Hep C. And I will say, this is a little personal, but I started shooting dope when I was like 14, which seems crazy now as an adult. And it was like the early 90s in the Pacific Northwest. And my eldest brother, he came up HIV positive when he was 16. And I swore to myself I would never do anything that put me at risk when I was 12, right? But I started shooting dope when I was 14. And I got hepatitis C like sometime in my late teens. I'm not exactly sure when. And I mean, just massive amounts of shame there, like shame and stigma, and just years of just thinking that like I wasn't worth anything. Like it wasn't even worth trying. Like, I'm gonna die young anyway. But I was actually able to get my hepatitis C treated at an opioid treatment program here in Georgia. I came down here about 10 years ago, and whatever, I won't get too into the specifics, but long story short, I'm 41 years old, and I no longer have hepatitis C, and I'm in recovery, and the likelihood of me dying from old age is like not only possible, it's more likely than anything. And like that might seem kind of silly, but for me, like it's amazing. It's an absolute blessing. It really is. And to be able to work with other folks that were so much like either younger versions of myself or versions of myself that, you know, I could say didn't get it, but what I might mean there is like didn't have access to the resources or didn't have access to people who wouldn't chronically judge them or discharge them, you know. And that's a lot to think about. Like, and I know a lot of us work for programs where that's what we do. Like we discharge people who don't get it. And that can be an intense thing. Okay, well, do we have any questions up till here?
No, just a lot of comments.
A lot of comments.
A lot of comments.
Okay.
Good comments, just a lot of comments.
I'll hit this one. And this is probably the most frequently asked question, right? This is, and I say that like people say this to me all the time, but won't giving drug users clean needles just encourage them to use more drugs, right? And I'm saying this and I'm answering this, but this isn't me here, Riley Kirkpatrick, answering this. Like harm reduction has existed for long enough that like there are plenty of research studies. We have statistics and we know that like the answer is no. Syringe service programs, needle exchanges, giving people clean needles, it does not encourage people to use who wouldn't naturally, organically use anyway. All that it does is help those that already were use more safely. And that's, I'll read that here. No, it doesn't encourage them to use more drugs, but it does encourage them to use the drugs they are already using more safely. While we wholeheartedly support substance use prevention and treatment efforts, we know that the most effective way to prevent the spread of HIV or hepatitis C is to stop it at the source, the needle. And that's exactly what I was talking about earlier. By meeting drug users where they're at and the spectrum of their use, we encourage any positive changes that our participants are ready and able to make. We know that our participants care about their lives and their well-being. We strive to provide the knowledge, tools, and support they need to make safer and healthier decisions. And that, honestly, like I wanted to get all like verklempt, a little emotional there. We know that our participants care about their lives and their well-being, okay? I know that now, but I used to not. Like, and it was weird. It was like I got into recovery and I believed this narrative that like, they don't give a shit. If they gave a shit, they would this, that, and the other. You would try harder. You would, you know, all these things. And like, it has been a really long process for me to like learn that there are narratives different than the one and only one that was the recovery culture that I was kind of raised in recovery. I don't know if that makes sense, and it feels kind of hard to explain, but I work with so many folks now who do use drugs. But when I look at them through lenses that like they are making their own choices and they're in their own power and control of their own lives. And I'm going to respect them no matter what. And I care about them. And I want to teach them that they are worthy of love and dignity and respect no matter what. And I will be here for them, whether they enter abstinence-based recovery or not. And there was a lot of years of my life where I didn't know that with recovery folks. Like I really thought that I was only worthy of support if I didn't use. But if I had setbacks or relapsed, or I mean, there was this whole thing that would happen. But
David Whiters wants to know, does harm reduction promote decriminalizing drugs, or are the two mutually exclusive?
no, and yes, they do. And if I had more time here, we would talk more about that, because yes, like harm reduction kind of as a whole. In earlier, like we can talk about harm reduction by means of the harm that is created with people, like individuals who use drugs. We could talk about the harms that are created in their community or in our community. And we can talk about the harms that are created like in society, right? And like the war on drugs, and the concept, the mindset that has created the narrative of criminalizing sick people, is really intense. And there is, and I'm gonna say this, and people might have different thoughts or opinions or whatever, and like it kind of, not that it doesn't matter, but it doesn't matter in that like numbers back this. Okay, like the war on drugs is really, really racist and really, really classist. Okay, you are going to have a completely different experience in America if you are a person of color, or if you are poor, if you're a poor white person. It's just how it is. I mean, we can look at numbers, we can look at statistics, and yeah, it's like, I don't know how we could be into harm reduction and want to reduce the amount of harm, have it only be on a personal level, but then let like the culture of the drug war create so much trauma and so much harm and break so many people, so many families. It's, yeah, I mean, I don't know how else to answer that, but yes, that is a huge part. There are people that work in harm reduction, and all they do is policy. All they work for is changing laws like that, right?
Mhm.
I mean, there are, I'll share this one thing, because I couldn't believe this, but it like, I was driving down the road in my car and I was listening to NPR, and they were talking about how they had passed a new ordinance or law or whatever, and it was specific to downtown Athens and football game days, right? So it was kind of becoming annoying when they would like take all the young drunk college kids and have to like put them in jail overnight, right? So what they did was they passed an ordinance that allowed, essentially, if the drunk college kid downtown could flash their ID card, their college ID, they would not be taken to jail. They would just get a ticket for them to show up to their court date, right? And you just look at the numbers and statistics, like it is predominantly rich white kids that have the ability to flash their UGA card, right? But like, there's no ordinance in the hood, right? Like there's nowhere else you can flash anything that is your get out of jail free card. It just does not exist. It's like not a thing, right? And we can't, I mean, we have a cash bail system that like, it's not about whether we're, harmful to society or not. Like it's about what you can pay, and like, who is it that can pay? It's not usually poor folks or whatever. But yeah, I mean, if I had, we go through a lot of this stuff when we do our Access Point volunteer training. And this stuff is, it is included. It is. That's not to say that everyone, I mean, we have volunteers that like aren't big, like we're not big advocates for this or that. Like, I don't know that we're advocating for much more than just like the ability to support and hold space for and want to help keep alive our brothers and sisters that are struggling and dying from substance use disorders, you know.
And then Alexius says, have you seen the harm reduction process lead people to abstinence?
Yes. Oh, yeah. Oh, absolutely. Well, and one thing, and I will say, I remember being in my CARES Academy, which I'm really bad at time. I don't know, maybe like 4 years ago. I don't know. And at this whole just kind of time in my life. And I remember like learning about, there was some study where like 22 million Americans identified as being in recovery, right? But at the time, like when I would say I identify as being in recovery, what that means to me is that I do work a 12-step program and I am like abstinence based, like what that meant to me was a very specific thing, right? But in this study, and there were so many people that like self-identified as being in recovery, or self-identified where like they used to have a severe, you know, alcohol use disorder or something, and like they don't any longer. And a lot of them, the ways in which they talked about being in recovery, when I learned about it, I was like, I didn't say anything out loud, but in my head, I was like, that's bullshit. Right? I was like, there's no way, or it's just going to be X amount of time. And then they're going to pull out their carpet slippers and that bottle of whiskey. Like I couldn't wrap my head around somebody calling themselves in recovery. And when they like were explaining a pathway that didn't look like the one that I currently did at the time, I literally like, there was some kind of disconnect there. Right. But to get back to your question, just the concept of people slowly but surely reducing their amount of harm until they got to abstinence-based recovery. Absolutely. Prior to what I'm doing now, I was I want to say one of the first CARES, but I might have been the actual first one that was like a CARES at a opioid treatment program, right? So like at the clinic, that in my whole thing there was like being a peer to other folks with medication assisted treatment. And prior to that, I was helping get the PROUD program off the ground, which was like a kind of similar to an OBOT, like an office-based opioid treatment out of Advantage, but was predominantly Suboxone. And we did eventually did Sublocade, we did naltrexone, Vivitrol, that kind of stuff. And oh my goodness, like, yes, there are so many people that I have seen get better kind of slow and steady. And honestly, when I'm really honest, when I stop and I look at my own history, like from that time that what I considered my bottom for a really long time to like what my actual date of last use is really different. But it was like my brain couldn't really notice because I wasn't really taught to notice that. But I absolutely, like, I was getting longer and longer periods of abstinence with shorter and shorter relapses to where it was just like a slip that was just a blip. And then would get longer and but like I didn't know about harm reduction and nobody was supporting me. Like I remember having a sponsor. I was trying so hard to not be shooting heroin, and my sponsor asked me how I was doing, and I was like, I'm doing well. I haven't shot heroin in like 2 months. I did have a couple days, like 2 days where I was craving so incredibly bad. And I like took a hit of pot at those times. And I told him that was totally like, I wasn't claiming anything. I was just telling him what had happened. But honestly, like on those 2 days, that hit a pot kind of helped me not shoot heroin. And at that moment, that was what was important for me. And he laughed and he was like, huh, is that like, so what? You're like kind of clean? Is that like kind of being pregnant? Like either you are or you aren't. And I was like, whoa. And like, I was proud of myself that I hadn't shot dope in 2 months. And that's not to say, and like, whether those hits of weed were right or wrong or good or bad, it's kind of not the point. But the point is that like, I felt like I wasn't worthy or deserving of support because I wasn't doing it right, you know? And I mean, it's many, many years later now. And like, if somebody else tells me a similar story, like, and it depends on who they are, it depends on what they want. Like, it's not my job to pour someone into a mold of what I deem as correct recovery. It's just not. Like, I'm not their God, you know, not to get too cheesy, but like, it's my job to support them and just like walk them in the direction that feels right and meaningful to them. And like, I do believe that like whatever we focus on gets bigger. Like I can focus on the problem gets bigger. I focus on the solution gets bigger. But when I'm working with somebody else as a peer, as a cares, like, no, I don't want to tell them what they're doing wrong. I'm not going to laugh at them and compare that to being kind of pregnant. Like, I'm going to support them. If they haven't shot dope in 2 months and they don't want to be shooting dope, I'm going to support them, you know? So I feel like that kind of answered that question, plus a whole lot more. Is there many other questions? I think I have like 2 slides left and we have like 5 minutes. So should I run through these real quick? Or
Yeah, just run through them.
yeah. So just as, and I was just talking about this, just being, you know, how can peer supports and harm reduction align? And I just want to be clear too, that like, I'm not like the intention of this isn't for anyone to like switch pathways or go like fly some kind of harm reduction flag, which one doesn't exist anyway. But just to like really let people know that there are pathways and ideals and belief systems like this where like we're allowed to support people in getting better. Like not in getting perfect, but in getting better. And like, that's okay. It is okay. And yes, many, many, many people get better at a slow and steady pace, and they're deserving of the support. So peer support and harm reduction align on meeting people where they're at and respecting the choice of the individual first. I was just talking about that with different words. Drug use and behavior is complex. Rather than ignoring, condemning, or asserting a just say no approach, it is important to reduce the harmful effects of the drugs. And actually, if I could write that over, I'd say, or the behavior, right? Like the behavior aligned with the drug use. When someone is in active use, they expect that the system surrounding them will shame and punish their use. That is so true. And that's just in that story I just told about, you know, my sponsor feeling humiliated by my sponsor. Peers can come from a place of non-bias and without judgment and open up the conversation for safer practices. And I'm not joking. When I started using some of these approaches with people I was working with, holy cow. Like when I stopped making judgmental statements, people will be wildly honest. So here's some resources, right? So these are the 2 SSPs. We've got the Atlanta Harm Reduction Coalition in Atlanta and Access Point, and we're serving surrounding counties also. There's also, there are some folks that are doing some stuff kind of on the DL in Augusta and in Albany. Okay, they're not above the table SSPs. But if there are people in those areas that need services, there are people that will help them who are also in recovery, who are in abstinence-based recovery, but are still helping. Harm reduction works. It got big over the pandemic too. It's a peer support group held online for those seeking support in minimizing harms related to substance use disorders. Kind of similar to 12-step, but not. Like there's readings and stuff, but what is in the readings is nothing like 12-step, but it's a meeting with a format similar to that. SAMHSA has a directory that's really good. If anyone needs any resources for like MAT, MAR, that kind of stuff, go to SAMHSA's website. Never use a lone hotline. I only have 1 minute, but y'all, this phone number right here, one of the biggest ways that people overdose is when they're using alone. And I am not exaggerating. Fentanyl is in all of the heroin around here. Like I could tell stories, but it doesn't matter. Just trust me. Like there is fentanyl in animal tranquilizers and no heroin, but it's being sold as heroin. But fentanyl is in everything. People will use alone and overdose. So you can call this 1-800 number, or you can tell people to call this 1-800 number if they are using and they're alone. Somebody will stay on the line with them, get exactly what their location is. If they become unresponsive, they will call EMS for them. Okay. I think that's it. Here's some stuff that's info for us. That's it.
Awesome, awesome, awesome. Thank you, Riley. And again, for everybody, I'll give it Riley afterwards, and I'll make sure that everyone who participated for the hour and a half gets the slides. So again, keep track of all your CEU trainings by writing down the month, topic, and panelists. In this case, it'd be September. The topic again was harm reduction basics, and the panelist, the facilitator was Riley Kirkpatrick. Did an awesome job, and I think that's it. Y'all have a great rest of the day. Enjoy your weekend. Thank you, Riley.
Thank you. Y'all have a good evening.
Yep.